And so I have put both lectures, undernutrition and overnutrition, together, and actually made it because it's two ends of the spectrum of childhood malnutrition, because malnutrition is wrong nutrition, although earlier malnutrition was directly or 100% exclusively considered as undernutrition. But today, as much as we still have undernutrition, we also have overnutrition to a great extent, and it's ever growing. So in this lecture, I will discuss both aspects with a small break in between. Now, malnutrition is wrong nutrition. It could be deficiency or excess. And now, when we take nutrients, especially macronutrients, because micronutrients are actually working as supportive cofactors or coenzymes. So it covers a wider range and requirements. The basic requirement is for the basal metabolism. Then also need for digestion and absorption, what is called the thermal effect of food. Then afterwards, there will be day-to-day activity. Normal day-to-day physical activity, basic needs, maybe wearing clothes, going to the toilet, things like that, getting the food, that type of thing. Then extra physical activity would be the next level of energy requirement. So when they have to exert, they want to play, engage in games, they have to have more energy for that. Then after going for those things, the next stage would be growth. And if there is anything in excess after fulfilling growth, it will be stored for later usage. Because humans, although we today have food 24/7, we evolved from times where there was food and there was no food. So in order to survive during the periods where food was scarce, then people should have at least stored some way of food inside their body, because there were no other storing facilities as we see today. So then there was seasonality. People would have not had a kill for a long time. So the hunter-gatherer, over a period of time, gradually improved on its, or the selection took place. Those who were able to survive during bad times and then store better during good times. So if you see, if there is a deficiency from this end, one by one functions will go off, because the nature wants to somehow or another keep an organism surviving for the propagation of its species. So without storage, without growth, without this extra physical activity, when a child becomes more and more malnourished or undernourished, they will stop. They will become first thin. Their growth will stop. And that means linear growth, mainly we are talking here. Then the child will be lethargic, not engage in adequate physical activity. Even day to day, ultimately what will happen is that person will be more or less bedbound. And then these two main functions would keep on. On the other hand, when we have excess of food, the optimum growth will take place, and then anything extra will store. Now, this is where the problem occurs in overnutrition, because the storage happens exclusively in form of fat tissue, and that is what is detrimental. Now, when a growth occurs, of course, linear growth, after some time, it will stop. It will not go, because we do not go beyond about average 180 centimeters. Only a few exceptions would be there. But in the normal, it is something between 165 to 180 would be the range. And anything excess will be stored. So that's why the vertical growth will stop, and then the horizontal expansion will take place, which is in the form of exclusively putting on fat tissue. So the macronutrients, what are mainly is the protein, fat, carbohydrates. So you will get overnutrition or undernutrition based on that. Then the micronutrients will be undernourished with vitamins and minerals, which is also called hidden hunger. You can't get over doses of vitamins and mineral, which will be not called as overnutrition, but actually as poisoning stages, because then they will have various effects. Now, for example, if there is excess of calcium in the body or vitamin D, then you will get nephrocalcinosis. Similarly, when you have hypervitaminosis A, there will be other side effects of toxicity. So, like that, especially the fat-soluble vitamins would get deposited in the body and they will have problems. Similarly, minerals. So, when we determine that a person is undernourished or overnourished, so the main thing what we use is anthropometry. As we discussed last lecture, we have to take the measurements, and measurements have to be taken in very standardized manner, because otherwise I will measure one set of measurements. One of you all do another set of measurements, the same on the same child, another set of measurements in few weeks or so. Then if they are not compatible, not follow the same standard, the readings could be different. There can be either under-reporting or over-recording or whatever. So it is important that everybody agrees on the standard practice and do the growth assessment that way. So mainly, I told you that we use weight as a crude rapid screening method, but main measurements would be the height, and then the indices would be height for age and weight for height, or BMI for age. So this depends on what we are using on the age. So mainly what we use is that for undernutrition, we use weight for height in children under 1 to 5 years of age or under 5 years of age. And if they are less than -2, they will be called undernutritious, and -2 to -3 moderate, and if it is less than -3, it will be severe. Similarly, the overnutrition or similarly the undernutrition in BMI would be more or less the same cutoff standard deviation levels. That is, anything less than -2 in the BMI for age chart will be taken as undernutrition or wasting. Then it is -2 to -3, moderate, severe would be less than -3. On the overweight component, the overweight is actually in the weight for height chart is taken more than +2 standard deviations as overweight, and then up to +3, it will be called as overweight. Above +3, it is obesity. Now, when it comes to BMI, of course, it is one level below. That is because you are using the height square here as the denominator. So in that case, you go on one level low. So +1 to +2 is taken as overweight, and above +2 is taken as obesity. So of course, there are a little bit of discussions going on about the sensitivity of this BMI in Asian populations, but it is beyond the scope of this lecture. But what you should remember is the underweight cutoff of BMI weight for height is same, but overweight, the weight for height cutoff is, and the BMI cutoff is 1 SD level below the level of the weight for height. I hope that is clear. So the charts are available. You don't have to remember things. So the weight for length chart or weight for height chart, you know the -3 line, -2 line, then the median, +1 line, +2 line, +2 line, and the +3 line. So median 1 + 2 + 3 plus, median 1 minus, 2 minus, 3 minus. So below this is severe. This yellow zone is moderate, undernutrition. On the overnutrition is +2 to +3 overnutrition and or overweight, and above +3 is obese. Whereas in older children, you get less than -2 as wasting. There is no clear demarcation given for severe wasting, but of course, anybody below -2 is considered significantly and intervention has to happen. Then those between +1 to +2 overweight and above that is obese. So this is what you have. So that's why just making the measurement is not correct. You have to plot it on the correct chart and then you have to interpret also. Then once you have interpreted, you have to take the intervention. So if a child is within the green zone, still you can't just forget it. You have to see whether there are any bad practices, improve on those, and then tell okay to maintain within this level. But anybody who is in these levels have to be intervened either to increase the nutrient intake or to reduce and correct the nutrient intake. So all 4 levels, that is obese, overweight, normal, and wasting, you have to have a quick dietary assessment and see what sort of a diet they are taking and whether that is healthy. If you need correction, you have to correct. Otherwise, you reinforce and tell them to continue what they are doing. Uh, is that clear up to now?
Yes, sir.
Right. Okay. Then we will get on with undernutrition. So undernutrition is actually not having adequate amount of nutrients. So it can be primary malnutrition or it can be secondary malnutrition, which is seen in disease states. Now, primary malnutrition is that food is not available. So they are not getting the food. Where it is mainly in dependent populations, children, elderly people, institutionalized people. So it may be hospitalized individuals or in convalescent or some form of homes, or it could be prisons where they are mainly not getting the adequate amount of food. On the other hand, secondary malnutrition, which is much more common, is the disease state. So when you are evaluating secondary malnutrition, you have to take a history and do the examination and try to find out from mouth up to the intestine or systemic body what has happened and see whether why there is malnutrition, because there can be a person who is getting the food but he can't swallow. There may be a pharyngeal incoordination, there can be a esophageal stricture. So any of those things will hinder them swallowing and retaining the food. Then after even taking that, some people may have severe reflux or some form of a disease and they may, or pyloric stenosis, and they will keep on vomiting. So they can't retain the food. They can't pass it beyond the pylorus. So that is another condition. Then of course they can ingest, negotiate the pyloric valve, comes into the intestine, but the digestion process is defective. Digestion enzymes are not there, pancreatic insufficiency, mucosal surface problems where there can be secondary uh, disaccharidases are ineffective or not present, like sucrase, maltase, lactase. So their digestion is not taking place properly. After getting digested, still there may be absorption issues could be there. One main thing is that there will be improper absorption surfaces. The child may have something like a villus atrophy, like in celiac disease, or there can be problems, something like bile secretion. So the fat and the fat soluble vitamins will not get absorbed. Or there can be not much of time where the child may have about, or adult or whoever can have in frequent bowel opening. If the person passes stools every 4 to 5 hours or even less than that, there is no enough transit time. So without having enough transit time, if the food ingestion to passage happens within about 3-4 hours, then of course it will be not effective. So there will be deficiency in nutrients as well as even in electrolytes. So then also the other thing is person takes the adequate amount of nutrition, absorption, everything takes place perfectly, but the amount required by the individual is very high. For example, there may be a heart failure person who is having tachycardia. His heart rate may be 110, almost double the normal. Respiratory rate may be very high, needs a large stroke volume to operate or something like that. So then, of course, your consumption of energy is increased. If there is infection, then the immune system is going up. So in those cases, the child will need more and more energy. So like that, you have to take the history to identify it, whether it's a primary or secondary. If it is a secondary, what is the problem? Is it a ingestion problem, retention problem, digestion problem, absorption problem, or whether the demand is very high in the body. So if you go in that sequence, you will not miss a possible cause for the undernutrition, because how much you correct the diet is not going to work unless you correct the underlying problem. So the WHO classification, which was moderate and severe, which I told you early, but it has two components. The weight for age is mainly for the wasting, the energy, whereas height for age, energy plus actually protein also. So the stunting will be thing. So they can have edema or no edema. So severe undernutrition is, or what we call severe acute malnutrition, SAM, is wasting when it is less than -3. For rapid screening, we can use the mid upper arm circumference. If it is less than 11 in the 1 to 5 year age group, we call it as, or we can lump them and then do the necessary further evaluation. This is the chart. So if you take malnutrition and infections, they go in a vicious cycle. So the low food intake will cause malnutrition. The poor environment will lead to infection. So when there is somebody is malnourished, the immune system is not functioning optimally, then they will get infections, and then it will alter the metabolic process. So malnutrition and infection are interchanged. So then the infection will cause alteration in metabolic process. As I said, it will increase the demand, and also it will reduce the appetite. So that will again lead to lower intake of food, and then it will further lead to malnutrition. So this goes on a vicious cycle. So that's why you have to improve the environment in order to improve the uh, improve the environment, to reduce the infection burden. So when you say environment, it is not only that you collect the garbage and throw and all that, but also you sort of start on doing vaccination and things like that. Then on the improve the low food intake, you have to improve the availability of food. Purchasing power has to be improved. Things like that have to be improved. So on those scale, you can break this vicious cycle at a point and then go on. So those are the main way of. So this is also important when you are identifying. You try to maintain, because there may be somebody who is earning 1,500 rupees a day, and the father may be spending 1,000 rupees on his alcohol and cigarettes, and then there is not much of thing. So similarly, the environment, clean sanitation, things like that, or there may be false beliefs and people are not going and taking vaccination. So those things also have to be corrected. So these are also part and parcel of your management. So there were actually, I'm just for interest sake, I'm giving this. There actually had been categorization, but in our country, we don't see very much of. What we see is marasmus, but marasmus is also not of the very severe degree we see today. And most of them are the prevalence of SAM, or severe acute undernutrition, is very minimum, and mainly it's secondary, but primarily MAM is more, that is moderate acute malnutrition or moderate acute undernutrition is much more prevalent. And of course, as I always say, one of the main contributory factors is improper commencement of complementary feeding. So that is one thing which we have to address. So it will look very thin, old person like, person with some amount of dehydration, and they are very alert. They are looking for food. Whereas Kwashiorkor is, of course, a little bit of a different, where they have a certain amount of calories, but their protein is extremely poor. Because of that, they develop edema, and then changes real to that will be there. So because the child is edematous, he looks plumpy, but of course, he is really wasted and having poor muscle mass, bone mass, and they are very apathetic, poor appetite, and they go into misery and misery because they mainly have a large fatty liver because of the high carbohydrate intake with almost negligible amounts of protein. So that is what happens in these two conditions, which we don't see actually Kwashiorkor very much in this country. Now, in order to maintain, now I told you when people go into malnutrition, the interest of the nature is to keep him surviving. So the nature tries to conserve energy in the individual. So how we can conserve energy is the cardiovascular system functions, or almost all functions in the body goes to a very, very minimum stage, which is only just to barely able to survive the individual. So in expectation of that, very soon the bad environment or the food availability will be improved. So the cardiac output goes down, the stroke volume goes down, then the liver synthesis of protein comes down, and then the genitourinary system, GFR reduces, sodium excretion is reduced, GIT and villus atrophy will occur, immune system get affected, and also endocrine system, because now we are there is no food to deposit. So then what's the point? There will be reduction in insulin. Then the insulin growth factor will go down because there is no growth, there is no fuel to support the growth. Then the growth hormones will go up because growth hormone is a stress hormone. Similarly, cortisol will go up. And again, thyroxine, because the metabolic rate has to be kept at low. So the thyroxine levels go down. So these are the changes that will occur with the change in the nutritional status of the individual. So management of undernutrition, what happens is that you have to take a history, which I told you, the medical history, to find out whether there are any medical conditions. So all that depends on how you sequentially take. And then birth weight, so immunization, which is needed for the management, as well as you can suspect certain illnesses. So like that, you have to take a history, the common normal history, starting from the diet from the mouth or the process that takes place, and then birth weight and how the child was growing, things like that. Then you examine anthropometry taken. Then you will look for the grading of the nutritional status. Then, of course, we have to do the nutritional assessment for deficiencies. The skin, vitamin, mineral deficiencies. The skin, for vitamin A deficiency in the eye, oral mucosa, skin. Then for iron, vitamin B group, oral mucosa, perianal region, oral cavity, for zinc deficiency, like that. You have to look. Pigmentation in pellagra, things like that have to be looked into. So that way you will be able to identify certain sections. Then you have to do investigation. So random blood sugar, full blood count, serum electrolyte, blood urea, because the investigations are done in order to identify whether there are any complications, and also to identify causes for the illness. So that way you have to structure your investigation, because without knowing the cause, exact cause, how much you try to feed the child is not going to do good, because you have to correct the underlying problem. Similarly, when the child comes with undernutrition, there would be a lot of complications. So you have to deal with those complications. So acute severe acute malnutrition, successful treatment depends on the time of presence. Earlier they present much better. But if they are gone into very, very difficult state, then problem. If they go into prolonged state without being getting detected, then they would come with complications. So sometimes children would come to the hospital because purely of a complication, then only. So that's why it is very important that each and every child, when they come to the contact of a medical person, to make an assessment of nutritional status, because he will be marginally undernourished at a point. But when you if you don't do anything, then what will happen is at the next time, the person will be coming with complications of malnutrition. So that is actually a shameful act for a medical person. If the person had seen the child 2-3 months before, did not intervene, then it is actually grossly a negligent part as well. Therefore, important to detect cases on an active manner. Otherwise, you will not do the job properly. So when you get a patient with severe wasting where the weight for height or the weight for length is less than -2, there may be having complications. There may be children without complications. They may be running around because they are still in the early stages. So if there is no complication, that means there is good appetite, clinically well, and then the child is very alert. So these children are easy to manage because they don't have any complication. So you can actually manage them as an outpatient if the bystander or the caregiver has a reasonably good knowledge about the situation. And then feeding, basic health care, nutritional counseling, all that have to be done. So you give the advice on the feeding, and then also how to feed, then how to nutritionally get the best food items cost effectively, and then the basic healthcare, include immunization, those things to be included, things like that. On the other hand, they can have a lot of other complications where it will be loss of appetite, lower respiratory tract infections, anemia, infections causing fever, dehydration. So all these things. So in those cases, you have to admit the person and manage it as as a inward patient. So the medical problems have to be dealt by the medical care, and then you have to start them on therapeutic feeding because the appetite may be poor, they may not be able to take the normal conventional food items, things like that. So once they have come here and then you have dealt with the complications, even though the child is still in the severe acute malnutrition state, you don't have to keep them throughout the hospital till they fully recover, but you can then manage. So once from this place they graduate into without complication state, and then alertness, appetite, all that improve, you manage as an outpatient person. Okay, is that clear up to now? Any questions? Anybody? Can you hear me?
Yes, sir. It is clear.
There are no interruptions, no?
Yes, sir. Yeah, no interruptions.
Right. Okay. Then there is a timeline. Actually, there are 10 points outlined by the WHO on this management, which will be helpful. So the time course is also important from the first 48 hours, then the balance up to 7 days, and then second week onwards. So by first 48 hours, you mainly concentrate on the complications. You are not trying to begin to feed from the word go. First, you have to stabilize the individual. Otherwise, what will happen is the child will die. So main thing is hypoglycemia. Immediately you have to correct it. Hypothermia, in this country not very common, but in other parts of the world, of course, in temperate climates where the temperature is very low, then of course this could be. So in Australia and all, of course, they can have such things also. Then dehydration, definitely you have to correct. Then electrolytes you have to correct. Sometimes You can't immediately correct that. Especially these people are prone to what is called hypernatremic dehydration. So sodium will be 160, 170, that range. So immediately if you try to bring it down to normal 140, 50 range, then of course there will be a lot of cerebral edema developing and problems. So that of course have to be managed very slowly and gradually. Then infections also from the first day itself you start, but of course full treatment will take about 7, 8, 10 days depending on the type of the infection. Then of course micronutrients where you have to provide, because micronutrients are important for the normal metabolism, infection control, and getting over the infection, that type of thing. So what we will do is you have to give them start on start on the micronutrients, especially the vitamin B group of micronutrients, because they are important in the management or in the processes related to the energy metabolism. And especially if you don't give thiamine, they can develop wet beriberi or what is called heart failure. And then you have to give phosphate also. Otherwise, ATP will not be developed, and the electrolyte. So all these will be deficiency. If so, we call what is called a syndrome called refeeding syndrome. You don't need to know anything deep into that. But if you know, one complication of enthusiastic feeding of a malnourished child would be, with improper feeding technique, would be uh, refeeding syndrome, where they will mainly have hypophosphatemic and electrolyte deficiencies, as well as heart failure due to thiamine deficiency or vitamin mineral deficiency. Then initially you don't give iron, because iron is one thing, is a corrosive. So the gut lumen is not very well now. It had been disuse atrophic. So there will be a lot of defects in the mucosal integrity, and iron can further damage. Furthermore, iron is needed for microorganism growth. And now there will be a lot of microorganisms, because the gut immunity has gone down, the motility is less, and when you give iron, they will multiply. Now, apart from that, there is actually, you all know, that there are gap junctions between cells. These gaps will be weakened, and any bacteria has the chance to invade easily through these gaps and enter into the blood. So they will develop bacteremia, and then they will develop septicemia. So it is important that you uh, first give the nutrients without iron, improve the gut lumen integrity, and then only from the second week onwards you start on giving iron. So initiate feeding also gradually, but it is mainly therapeutic feeding, not very nutrition laden or increased feeding. Now, one thing you have to remember is actually this Rosomal is a commercial preparation, but I told you that these children are dehydrated, and their dehydration is hypernatremic. So the normal 2 ORS which we used in the past, or still we are using the new ORS, which contains high amounts of sodium, because this was made for diarrhea, infective diarrhea. So infective diarrhea is a process where salt is lost, mainly sodium. So they will be hyponatremic dehydration if at all. So you need to replace the sodium. But here in this group, if you give this, there can be further aggravation. So that's why there is a little bit of a less sodium containing, and the same time their potassium content is also low. So because of that, the potassium content high solution has to be given. So because in the malnourished child's dehydration, which is a non-diarrhea, non-vomiting, non-infective dehydration, their normal baseline sodium is high, potassium is low. So you give a low sodium, high potassium containing preparation. So they have added some other minerals also. And so this is helped to improve the electrolytes apart from improving the fluid. So it's a commercial preparation. Now, what do you do in the inpatient management? You have to start the initial feeding with low osmolar foods because the intestine is now having villus atrophy. It had been not used properly for a long period of time. There had been nutrition deficiencies, and as a result of that, they can't handle large osmotic loads. So because of that, you tend to give low osmolar solution, and you also start with low calories, because if you try to give large calorie amounts, then of course the osmolarity will also go up. So you start with about 75 to 80 kilocalories per kilogram for the current weight of the individual. Because there was a practice that you try to give an arbitrary weight. No, you have to feed the living child. So you give the correct amount to the calculated to the current weight of the child. If the child is actually 8 kilos, but by now the median for that particular age, if it was 12 kilos, you don't feed for 12 kilos. No, even for a middle point like 10 kilos, but you just feed for 8 kilos. So you calculate your calculations for that and you start. So then you provide the micronutrients, as especially vitamin A, you may have to give it. Then things will get gradually improved. So you have to increase the calorie. So your 70 to 80 kilocalorie. If the child is tolerating, you make it 100, 120, 200. Like that, you can go on. And in that process, now we knew one main thing is in any animal, the rate limiting factor for volume of feeding is the stomach capacity, because you can't eternally give any amount. So it has to be held by the stomach. So if you are going to give a low caloric dense component like F75 or F75, then you have to give very large amounts. Then, so you can increase the calorie density. So 100 ml instead of having about 60 or 70 or 75 kilocalories, if you can give still 1 ml or 100 ml containing 100 kilocalories. So then you are increasing the calorie content by about 25 kilocalories. So then the volume will again come down. So that way it will help. Now this F75 is actually 75 kilocalories per 100 ml. This actually came as a commercial preparation, but any food item, if you can prepare with this much of kilocalories, you don't have to go, because this is actually a trade name. It is not a generic term. Similarly, if 100 is also like that, because to cater to the needs of especially the African continent, companies came up with this, and that's how they have been feeding. So then you can give 3 to 4 hourly feeds, about 6 to 8, and provide the required kilocalories. So the main limiting factor is actually the volume of the stomach rather than anything else. Then gradually now the calorie density, which is 100 kilocalories per 100 ml, will not also be sufficient when you are increasing the kilocalories to about 170, 180, 200. So you have to go for much more calorie dense product. That is something like what we call ready-to-use therapeutic food, which will have about 500 kilocalories per 100 grams of the product. So you can give this, which comes in more of a solid form of a diet, and then you increase the liquid diet gradually. So how do you know? Now, first week, you don't actually assess whether the child is gaining weight or not, because the other things have to be stabilized. And then from the second week onwards, you can see, okay, whether my management is working. So you can give and see whether the person is gaining 10 grams per kilogram per day. If that is the case, then you are very happy. But if it is something between 5 to 10, okay, manageable, it will hopefully improve, but you just see and make sure whether you can improve further. But if there is a weight gain less than 0.5 grams per kilogram per day, that means there is an issue where either your diet is not working or there is an underlying problem which you have still not addressed. So you have to correct that. So that is how you do the evaluation. So these are some of the other preparations which will have 75 kilocalories per 100 ml. So actually the milk, you all know, normal milk what we drink has 60 kilocalories per 100 grams. So you can make even that and add a little bit of sugar that will come into, or you can add a less amount of milk and more sugar. So whatever it is, you can take the and make it a solution of which we have desirable amount of calories. So there is nothing magic about this F75 or F100 because people think most of the time these are actually generic products like you are giving amoxicillin or amoxiclav or something for infection. You have to give F75. There is nothing like that. You have to provide the calories. And there had been a commercial preparation. So if you want, you can have Cal 75 and produce a preparation. If tomorrow comes from another company saying Cal 75 and Cal 100, similarly, you can use that. So, but here you also can prepare and need not be exactly a 75 kilocalories. It can be 75, 80 kilocalories per 100 ml. And if it works in the body, then you don't have to worry very much. But the whole idea is to have a low or smaller and then go into a little bit of a high calorie dense food later on. So I told you ready to use therapeutic foods. Now there is a fashion, of course, everybody say no sooner they diagnose undernutrition to go for ready to use therapy. There is nothing like that. You can first start actually on household. When there is a difficulty in giving the calories, only you should be using. So this is actually a prescription product, not available in the outside markets, but only in tertiary care hospitals. So these are the two products, what is called BP100. Then there was another thing called Plumpinate, any of those, and you can see the calorie density. 92 grams, 500, 100 grams here, 527. So you can see more than 500 per this thing with other nutrients. Then what happens is they will see catch-up growth from second week onwards. As I told you, now they are beginning to gain and try to come back to the normal level. You have to stimulate them. That will improve the psychosocial interactions and the appetite. Then once you come to about 3, 4, 5 weeks, if the child and the bystander is now doing things better, you have to plan to discharge them and follow up later on. So appetite goods, medical complication control, edema is minimal. But always you don't have to have the weight for height above minus 2 SD. If it is there, it is okay. But that is the end point of looking after, but not for this thing. And then what you are going to do is that on discharge, you may initially give probably reduced therapeutic foods, but you can go on for other cost-effective programs, either Triposha or corn soya blend. Now, Triposha has a calorie density of about 400 kilocalories per 100 grams. So that is also fairly calorie dense. And if you add on a little bit of more things like sugar and coconut, you can further improve it to by about another 50, 60 kilocalories. So that is what we use. Now we started the child here. We treated the complications if we had, or otherwise we just began to feed, improve the feeding, and gradually it began to rise. So the height also he will gain gradually, weight also he will happen. So you can see that the things are growing fast, and then it will cross the minus 3 SD line. Now this time is child is no more severe acute. He is moderate acute in this level. So you don't stop here, you still go here. Even when they are moderate acute, you don't stop. You just continue the same follow-up you will give. But of course, after, when they cross this level, you can't use ready-to-use therapeutic foods because ready-to-use therapeutic foods is mainly for severe acute malnutrition. But if it is moderate acute malnutrition, then of course you use to give other supplements like Triposha or CSB and then other food items. And at home itself, you can improve the calorie density. And then they will go on. So like this, the weight will go on. And you wait till they cross the -1 level. Because if you leave them here, then they is very vulnerable to come back down. But if you go up to this level, then their appetite improves, the amount they want to eat will improve, and then they will go up. So you have to continue the management or follow up till about -1 SD, but that does not mean you have to depend on therapeutic food items or supplementary food items like reports. You can stop that, but you have to continue and make sure that the child does not fall back into the undernutrition status. So is that clear up to now? Any questions? I don't see any chats put on. Are you all clear? Anything to be clarified? So you identify the nutritional status. If it is undernutrition, you try to find out the cause. And then if it is, you identify the cause, you try to treat that. While then you start on management. Initial phase is acute is actually looking for complication treating, but you start on the mineral vitamin supplements without iron, and then the therapeutic feeding with a low osmolar diet and low calorie density, but gradually you increase the calories and the osmolarity with that. And then you follow them up till they reach -1 standard deviation in the weight for length or the BMI for age actually. And then it's mainly actually we talk about SAM MAM in under 5 years. And then once they come up to -2 only, you will stop them following up. Is that clear?
Yes.
Right? Do you want a break? 3-4 minutes before we go to overnutrition lecture?
Yes, sir.
We'll take a 5-minute break.
Okay, sir.
Length or weight for height above +2 standard deviation or BMI above +1 standard deviation. Actually, obesity, which is above +3 standard in the weight for length, at above +2 in the BMI, is actually not increasing the body mass index per se. It is excess body fat in the body. But if you get an athlete who is doing physical training, then of course the body muscle mass and the bone mass will go up, and they can become having a large BMI, which is actually, truly speaking, not obesity. But in the general population, somebody puts on weight that will be viewed to excess food intake and increase sedentary behavior or reduce physical activity. They will deposit the excess calories as fat. So when the body fat increases more than 25% or so in the male and more than 32%, it will be identified as obesity, because at this level, at these levels, they will develop uh, complications related to the fat deposition. So that's why obesity is now identified as a disease condition. Now we know this. We just discussed about that. So when we see a child, and in last time lecture also you saw, when a child is growing in weight, his height will also grow, and then it will stop at a particular point. But sometimes the height will not grow, and the weight will grow exponentially than the height. So in certain obesity cases, there are syndromes where are different underlying diseases which causes obesity. Whereas the primary or the commonest cause for obesity in today's context is overeating or excess nutrition retention. Again, there may be certain metabolic problems underlying in the body which causes them to retain more energy, at which we will discuss it later. But primarily, it can be either syndromic obesity or non-syndromic obesity. Now, syndromic obesity is actually, they will be relatively short. That is, in the weight for length chart, they are not going to be less than -2 always, but at least they will be below the median. Whereas the BMI and the weight will be well above the median, that is more than 2 SD or so. So what are these syndromes? So what we call them as short obese individuals. So that is low Down syndrome, Prader-Willi, Bardet-Biedl, something like that. Then endocrine conditions like Cushing, hypothyroidism, hypoadrenal then hypophosphatemic rickets, growth hormone deficiency. All these things will be a short and an obese individual. Whereas the tall obese ones are actually due to excess calorie intake. But the calorie intake could be not just they are eating, but they are being pushed to eat, like in single gene disorders, where congenital leptin deficit. You all know leptin is that is there to say, okay, don't eat now. Now you have enough. But if the leptin is not functioning properly, then it will keep on feeding the individual. It will give the individual to just keep on eating. So for that, they will there is a disease, but disease has led them to eat more, and that increased intake of food has caused them to become tall obese individual. Then similarly, things like welfare, physical disabilities, psychological problems, adolescents with IDDM also lead, because adolescents, they take their insulin, they are rebellious, they want to be with their peers, so they want to eat like the others. So in order to overcome that, they will inject high doses of insulin. The insulin will have the anabolic effect, it will go and deposit. So ultimately, they will become obese. High sedentary lifestyle. That is, they just sit and do things without physically moving. So these are the main things that will affect, and so they will grow tall. At the same time, they will become obese also, because have now come and stopped at the maximum amount they can grow to their height, but they are continuing taking food, so that will deposit in their body. Now you can find out from the literature, from head to toe, any organ in the body can get affected. Main two problems is the metabolic syndrome, that is insulin resistance, and on the other hand, the problem is what is called non-alcoholic fatty liver disease. Now, metabolic syndrome occurs, and I think it has been dealt in the endocrine and metabolism module, what happens there, but it is primarily due to the childhood or adult obesity, and how it is diagnosed, all I'm not going to discuss here. Now, you can suspect metabolic syndrome in children because when they have acanthosis nigricans, this type of a change you will notice, and then this will be actually a hyperplasia of the keratinocytes, and you can see an increase in the thickness of the skin. It is not just a discoloration, it is increased cellularity as well as pigmentation, and then this will also disappear when the insulin resistant state comes down. So in other words, if somebody begins to lose weight, then the child will also begin to lose this situation. So that is where it is important, because the parents otherwise sometimes keep on going to dermatologist, and various other medication could be given. And more than that, what you can assure is if they have this, they have now already begun to develop metabolic problems. And on top of that, when you go on a proper diet and do the exercise and reduce your fat content of the body, this will also disappear. So even without a weighing scale, you would be able to gauge whether the metabolically the child is healthy or not. So what are the goals of management? One thing is we have to reduce the weight. That is very important. Then we have to treat any morbidities. Now they can have hypercholesteremia, hypertension, insulin resistance or pre-diabetic state, fatty liver disease. So you have to make sure that you treat this also. And now we know that this is a whole change in their lifestyle, because they have been fancily eating. They have been sitting and trying to do a lot of sedentary activity, either screen watching or screen using or whatever. And also they are evading physical activity because they are lazy. And now all these have to be totally almost changed upside down. That is, you have to cut down the calories, cut down the sedentary time spent, and then increase the physical activity. So because of that, the psychological adjustment is needed. Furthermore, the psychological adjustment is not only for the individual, but for the family as well. So you have to have a big haul psychologically, the parents, siblings, in addition to the child. So when we diagnose obesity, we have to look for basic metabolic problem. So then we do a fasting blood sugar. After about 12-hour overnight fast is enough. Then we do a lipid profile. So you will get the triglyceride, HDL level, total cholesterol levels there. Then we do the ALT and AST levels, because that will give a clue to the liver profile, or what is whether there is any damage in the liver. And usually the AST is always higher than the ALT, but in fatty liver disease, ALT is higher than the AST. So this ALT to AST ratio will be more than 1. Even if there has not any damage, ALT AST is within the normal limits, still if there is a reversal in that, that means there is early changes in the liver taking place. Then you, after taking blood for that, you give them a glucose load, and then take 2 hours later, you don't have to do in between, 2 hours later you can do the OGTT, where usually it is, you all may have learned it as 75 grams of glucose, the maximum. That is actually what we call anhydrous glucose, but we don't have anhydrous glucose in the normal community. We have what is called monohydrous glucose. That is, every molecule of C6H12O6 have also one H2O molecule. So that means they will be having water also. So apart from the 180, you have to add another 18 also for the molecular weight. So for children, the maximum is 75, but it has to be calculated as 1.75 of anhydrous or 1.92 of monohydrous glucose per kilogram to a maximum of 82.5 grams, and then given within about 5 minutes, dissolved in about 100 to 150 milliliters, and after 2 hours only. There is no need of a 1 hour test to be done, because sometimes when you write to the laboratory, they will say they will take, because OGTT is supposed to be taken every half an hour blood samples, but here it is not necessary at all. For the interpretation, a 2-hour value is more than enough. If it is below 140, it is normal. 140 to 200, it will be impaired glucose tolerance. Above 200, it will be diabetes. Then, of course, you will have the ultrasound scan of abdomen, mainly to find out what is happening in the liver. So if you have these things, with these two and the OGTT, you will be able to identify metabolic syndrome in addition by measuring the blood pressure. And then ultrasound scan and the ALT will give a clue about the liver state. So what do you do management? Apart from taking the investigation and find the complication afterwards, you do a behavior modification. You change the dietary pattern. You change the activity pattern. You have to increase physical activity, reduce sedentary behavior. And as I said, you have to provide the psychological support. Now, pharmacology, you have to use if there are complications, like I told you, there may be hypertension, hypertriglyceridemia, or hypercholesteremia, that type of a thing you have to treat. And for obesity also, we have to sometimes, they may not have many problems, but there can be a little bit of high insulin resistance. Diet has not touched, and then you can use some pharmacological agents, and especially metformin is useful because it has lowering of the insulin resistance, as well as it has improved increase poor appetite. So it is a way that they will reduce intake of food. And in Sri Lanka also we have done a study which has a double-blind placebo-controlled trial, which has clearly showed that the the metformin supplementation has done good. Then if those things are not working in a little bit of older age, adolescent age, they have very high morbidity. If the BMI is maybe about 35 or so, and it causing a lot of problems, then of course you may go and do a sleeve gastrectomy and improve the metabolic process. So these are the available, but of course 99% of them would be able to manage properly if their compliance is good. So when you get a child, first you have to identify obesity. Then you calculate what should be the ideal weight for this time, or the maximum allowable weight. The ideal weight is getting the median of the BMI. The best option would be, at least if they can get to the +1 level, where it's just at the overweight cutoff. So what you have to do is you have to work backwards and tell them. Because if you tell, okay, your BMI, or the parents that your child's BMI is 21, ideally it should be only 17, okay, it will not really make them understand. But if you tell them, okay, your child is 52 kilograms, but ideally he should be around 35 or 36, then of course parents will really begin to think and appreciate, okay, my child is 14 kilos in excess. So then they will take action. So how you do that is you take the +1 standard deviation value for their height, for the age, and then you multiply by the height square of the child. So, and then you will get the figure, which is the kilograms that should be. So you can tell the parents, this is the maximum that they can have. But another 2-3 kilos, it should be less. Because on the other hand, what happens is, on the other hand, what happens is that the child will gain height also. In opposition to adult obesity management, the advantage we have in pediatric obesity is, if you can bring down a little bit of the weight, or even if they are just at the obesity cutoff value, and if your child is really pre-pubertal child, you try to maintain the weight, then their BMI will come down because the weight will be maintained, but over the period of time, the height will go up. So in order to definitely maintain the weight, you have to cut down certain amount of calories. So when you review them in 1 month's time, if the weight has been static, so 52 kilo child had remained at 52s, that is some achievement, because the rate they put on is actually 400-500 grams per month, which should not be that much. But if you can stop that as the first step, that is something that they have achieved. And then gradually the height will go up. So, but in the meantime, of course, then afterward, the second, third time, you can say, okay, you come in 2 months' time, but you have reduced at least to 1 kilo. If you can reduce 2 kilos, fantastic. So then they get motivated, then they will do. So the targets have to also be, so you tell them, okay, how much away they are from the ideal weight, or at least the ideal, the maximum allowed weight, because the ideal should be the BMI at the median level. Then once you have given that, the first target is, okay, come next time without getting increased weight. Once that has happened, okay, you try to lose weight, that would be the next target. So like that, you give targets rather than trying to bring down the BMI overnight to the acceptable limits. So the dietary guideline, at least you have to increase the servings of the fruits, eat adequate amount, less refined food, drink plenty of water, because that is one of the biggest problems what we are facing in this country. People are taking large amounts of sweetened beverages instead of taking water. And you all can see sometimes some people say they can't eat because there are no certain beverages. So my question is, okay, right, very good. That is what we want to achieve, not to feed the fellow. So tell them not to eat. At least 2 portions of less fat dairy serving. So ideally, we should tell them to take low fat or non-fat milk as part of the diet. Then protein also, sometimes we take protein, but invariably they will take large amounts of fat hidden under the protein components. Fish consumption is good because it has good favorable fatty acids, and then the salt intake because they are the complication. Now all this we can tell, but nobody will understand or will appreciate how much I should be giving my child, because these are all arbitrary figures. But people tend to now have a little bit of more understanding, and as a result of that, they will take some amount of measured weight. So what we do is we give a guide, because the food-based dietary guidelines can provide, and you can, anybody usually sensibly can categorize the food, whether it's starchy foods, vegetables, legumes, fruits, milk or dairy products, then the animal proteins, with the extras also, because people like to eat other sweetened, salty, uh, what do you call, oil rich components also, but they should also be given in a limited. So that's based on the age. For a total day, you will say, okay, this much of portions you can allow your child to take. Then, because we can't be giving a prescribed diet, it is not practical. So you tell them from each food group, you take this much. So you organize the day. So then we give what is meant by in each food group, what are the food items and the with measures. So when it comes to starchy food, you can see it will be half a cup of rice, 1 slice of bread when the loaf is cut to about 8 or 9 pieces, then 5 string hoppers, 2. So they can have whatever they like to eat, but we are guiding them on the volume. So similarly, fruits, vegetables, but of course, fruits and vegetables could be increased. And also, fruits and vegetables are less calorie containing, or the calorie will not be released if you ask them to take it as a raw food item. And then when it comes to fruits, if they can take it as a less ripened thing, because ripening will increase the amount of sweetness. So that way you will give them the dietary advice. So more raw vegetables, then under what do you call, fruits which are not ripened. So that way you will be able to give. So for milk also, you will give the guide. So that way the child will be able to take the food. Any questions up to now? No, all are sleeping. Looks like. Ne? Right, okay. Going on to activity improvement, you have to cut down the sedentary and then try to do extra physical work, regular sports activity, then daily physical activity for minimum 60 minutes. After activity to relieve, they should take water, and then they should not take large meals, and then never to do things for children that they should be encouraged to do and made them independent. Now these are also what we have been doing. But of course, there is guidelines now put out by the WHO, and this guideline came April 2019, and this guideline was released only yesterday evening. So this is hot stuff, which is both are available in the internet, which you can download and read. Both documents were contributed by Sri Lanka as well. So what we have to do now is see now what has happened actually. These guidelines are given mainly through 24-hour behavior. Now, there are 3 components when it comes to the activity of an individual. That is the sleep time, sedentary time, and physical activity. So it's because sometimes some people will work they will do vigorous physical activity or moderate to vigorous physical activity, maybe about 1.5, 2 hours a day. But if he sits in front of the television and watch TV and spend about 10 hours, then there is no point of doing that physical activity. And also the other important thing is the compromisation of sleep. If that's why I have been telling even your final year colleagues that they should have adequate sleep because it will keep you physically also healthy as well as mentally healthy. So there are at least when it comes to your age, people should sleep at least about 8 hours a day because that is very important. Otherwise, it will not really be helpful psychologically or mentally as well as physically. So these are the three components which you have to organize the day. So what are the durations? All that we will try to discuss a little bit. So when it comes to the sleep, you can see different ages will have different levels, and you can see with the increase in the age, the duration of sleep come down. So when it comes to about above 18 going up to about 50 to 60 years, it will be around roughly about 6 to 8 hours duration of sleep is required. So that way, that's why I said at least you all should sleep about 7, 8 hours a day, and that should be a very sound sleep. Then sleep, of course, as you can see that there will be a lot of important benefits. The attention will improve, behavior will improve, learning, memory, all that. So inadequate sleep will increase injuries because people are not very distinct. Hypertension, obesity, depression, all these could be. So you can see sleep is a very important thing because the humans have evolved as as day creatures where they are sleeping at night. So usually the ideal that they have described is 10 p.m. to 4 a.m. to sleep. And you can see even how we have been doing in the hunter-gatherer age with the sun going down, people began to sleep. And then when the sun rises, people came up. The whole thing was turned upside down when Benjamin Franklin and Thomas Alva Edison developed the electricity or discovered the electricity and invented the bulb respectively. So that has really revolutionized, or not revolutionized, I would say, that had worked into a detrimental state of our health. So we have to remember that we have evolved in a certain manner. Our bodies are made into a certain manner, and we are not owls or bats who are having a night life, but we are humans who have been developed or been designed and made as day creatures rather than night creatures. So we have to respect that if we want to be healthy. Otherwise, of course, we can go against that and be unhealthy. Then sleeping also has to be very methodical in a way if you want to get the maximum out of it, that you have to have regular times of sleep. Today you can't sleep at 8 o'clock and tomorrow you can't sleep at 10 o'clock. Then the next day at 7 o'clock and the next day at 1 a.m. in the morning. You have to have a regular time. If you begin to have a regular time, then the amount you have to sleep is also relatively less. So if you have the correct bedtime as well as the wake up time better, you have to avoid things which will prevent you getting sleepy. Things like chocolate or coffee or things like that. If you can wake up to the bright light rather than a natural way, rather than keeping an alarm and always trying to wake up, that will be much more better. Then when you sleep also, it should not be disturbed by any light or anything. Even if there are any street lamps, you have to make sure that you cover them adequately and uh, get a good night's sleep. Then you should not go to bed hungrily. You can relax reading a book or something. Screen devices are prohibited at all times. You should not be keeping, and because the radiation from the light will not be conducive to the eyes, as well as also you should remember that the radiation always that is there. So whenever possible, whenever not necessary, try to keep the telephones switched off, because that will prevent you from having unnecessary radiation, which could be a lot of harmful. And then regular exercise during daytime will help you also to have a good sound sleep. So these are some of the points that you should remember. Not only remember, my advice is that you all also practice this, because that will keep you much more healthier. So then for the older age, which came out yesterday, at least that is 5 to 17 years, at least 60 minutes per day, moderate to vigorous physical activity. What is meant by moderate to physical is that you can't do vigorous physical activity of 60 seconds. Vigorous physical activity is defined where somebody exerts and he can't actually speak because his heart rate, respiration is so much high. So they can't complete a sentence. But moderate is that so you can see you can't keep on doing like that for 60 minutes, but you will do for few minutes, maybe a minute or two, and then you have to have a little bit of relaxation. They are moderate. So the example I take is somebody, a footballer, keep on sprinting and taking the ball from the midfield up to the goal. He then only stops after he kicks the goal, and then whether he succeeds or not, then he begins to relax and he just jogs back to the midfield. So that way is the thing, because he does not keep on running all like a madman. So that way you can understand what is meant by vigorous, moderate and vigorous physical activity. Then at least they should do uh, some form of aerobic activity. Then again, for older age also, you have to limit the screen time. Now screen time is actually not advisable for children under 3 years at all. No screen is told to be advised to be taken. But of course, for educational purposes, maybe 1 to 2 hours is allowed. Then in the older age also, unless it is really, really important, for especially for recreation, they should be stopping that, because they should not be spending. And then on the other hand, if they are watching television or any of these screen devices, I hope you all know that this minimum distance that they should be kept from the eyes. One thing is it should be kept at the level of the eyes or a little bit lower, rather than, and the neck should be kept straight, because what happens is ultimately there will be a lot of strain on the neck muscles if you keep the head flexed. So that is another syndrome, another illness that is now also coming up, where there will be neck pain in these individuals. Number two is that it has to be at least 3 times the size of the screen, the distance between eyes and the screen. So if the screen is, we'll say it's a 10-inch tablet device, then of course it has to be 30, at least 30 inches away from the eye and kept at the more or less at the level of the eye or little slightly below. But the neck should be kept straight and then functioning. So that way you have to make sure. So remember that physical activity is important, and also the main thing is there should be exact amount of sleep. Then the the sedentary behavior is, again, the time is limited. You can't have it more than that particular time, usually about 2 hours or so, 2 to 3 hours mainly. Then on the other hand, you have to make sure all the other time you are physically active. That does not mean that you have to go to the gym or play or to the playground and play for this thing. That of course minimum of 1 hour of moderate to vigorous physical activity as a structured program you can do. But all the other times you should be trying to walk, keep on standing, things like that, and make use of the place. So that's why even if you can climb 1 or 2 flights of stairs, that would be the best thing, rather than taking the elevator going up. Sometimes people take the escalator without taking the steps, or at least you should try to come down if you're finding it difficult, but you have to mind about the health of the knee, because otherwise there will be a lot of strain on the knee. So, but that's where you have to try to be active all the time as much as possible, but limit the sedentary behavior and have the adequate amount of sleep. So those are the main things which you have to do in management of childhood obesity. Then of course in the prevention also, just quick word, we have already discussed that, because we have to make sure that we give the chance for the individual to grow optimally. So we can't cut down, and just because the weight is going up, I told you last day that we can't uh, decide, okay, it is not good. We have to cross check with the height and see whether weight for height or weight for length is going up, and then we have to optimize the nutrition, because otherwise they will keep on growing unnecessarily, and the general public thinks a fat child is more healthy child and fat child is the better growth child. But of course that is wrong. Now we all know that. So what will happen ultimately, they will grow to fancy the parents or the adults eyes, but of course 15-20 years later the child will have to pay the price, spending hours and days either in the OPD or the clinic queue or in the hospital. So that is why you have to give not less and not more, and make sure that they grow optimally without being able to adversely pay later in life. So appropriate growth guided by the growth chart is important. So that's why till 18 years, you and I have to use the growth chart and the charts appropriately. So this, of course, you can remember, just to recap, those who are growing rapidly, whether it is physiological or whether it is obesity. So you have to match with the height for age, and you will remember this, where do we stand, whether it is between the -1 and +1 in the weight for length chart, or maximum would be -2 to +2, or whether it is above. Then you have to take the action accordingly. So that is the lecture. And there are a few questions, I think. With families that consumes thosai, vade, biryani, like traditional foods, how much should be taken? Well, of course, some of these items, there is a booklet if you can go and get from the, where shall I? What I can do is I can leave a copy in the library, and then you can get a photocopy of that. Today I will try to leave a copy of this booklet which we give as dietary advice to parents. You can take a photocopy of that, and then you can understand what I am telling. If you, in that list we have given most of the food items, but if there is no such thing, then you can take the same, more or less the volume. For example, if it is half a cup of rice, because thosai and all will have not only wheat, the flour, the other ingredients also there. So roughly, if it is matches about a 3/4 of a normal teacup. When we say a cup, it is the 200 milliliter cup. If it fills that much, then that, or size of a slice of bread where the loaf is cut into about 8 or 9 slices. So if you can roughly make the volume out of that, that would be some amount of assumption. But if it is, that is not quite correct biochemically, but of course you have to give some guide to these parents. And we are not doing a scientific experiment here. We are just trying to modify their diet and give a conscience, or may create a conscience about the amount that they are eating. And gradually, when you give less amount of food over a period of time, the amount they can eat also get restricted. So that way it will help to curtail excess calories. I hope it answered your question. Should these sleep hours be at a stretch or do naps during the day? You can have small 1 or 2 naps, but of course the bulk of the sleep should be as a single stretch for a considerable period, because otherwise you will not get a proper resting. And the ideal, as I said, it is between 10 p.m. and 4 a.m. following day morning. There are children who are lean even though they eat more than enough. If they continue with, they have complications later in their life. Well, what people sometimes happens is their metabolic rates may be high. Their physical activity levels could also be high. They may be energetic and moving around. Their thyroxine levels may be high or whatever. But having said that, if they eat the wrong thing, they may be lean. Sometimes what has happened in the South Asian context is we see people lean. Their BMI may be just at the overweight level, but they of course have a lot of complications. Why? That is because their fat content in the body may be high. Their lean mass, that is the bones, muscles are not enough weightage, but they have a large amount of fat which is hidden under that. It is overall not putting out, so they can. And on top of that, even if they are burning things like that, still they can have deposition of cholesterol. They may be lean, but they can have high blood pressure, maybe familial, or their salt intake is high, and because of that they can have high blood pressure. Then that will damage the wall. So there are a lot of large things. But of course, having said that, if somebody keeps on eating unnecessarily, then of course they can have, because the problem is if they stop or they reduce their physical activity, no sooner they will begin to put on weight. So they have to be careful. Do we discharge the monitoring of obese children after they achieve the recommended weight? Yes, of course, yes. But we have to alert them, tell them that they have to be on the watch out. So once they have achieved the adult height, of course, it is easy because then they will not grow. Then their BMI will also be static. So then you can convert the BMI matching their height to the weight to appropriate their height. So say, okay, 180 centimeter tall person now has stopped to have 23 or whatever BMI. Okay, you should maintain your weight between 70 and 75 kilograms or something like that. So that's a reasonable age. So the weight then they can measure, then by that itself they can. But as I told you earlier, more than that, one of the most important thing is to maintain the waist circumference, because sometimes what happens is when people are exerting a lot, or in other way, if they are doing a lot of physical activity, and sometimes they may go to a gym, do weights and all that, with that their muscle bulk may go up, so their BMI can, or the weight may be at the higher level, and they may not. So if they keep on looking at the weight daily and get depressed, okay, the weight is not coming down, and then they keep on doing more and more harder exercises, workouts, then they further keep on increasing because their muscles and the bones get more and more stronger. But if their waist circumference is maintained, as I told you, below the 0.5 ratio to the height, then of course they are fairly safe. So the waist circumference or the abdominal obesity is the main problem. So because these have to be balanced, and you have to be knowledgeable about to tell them, explain, because they will come and say, doctor, I am doing so much of exercise, my weight is not coming down. Weight will not come down after a point, and more you do, weight will remain the same, because your accretion of bones as well as muscle will be taking place. You retain more water in the body. So you have to tell them. If somebody is getting afternoon naps, how long is it advisable? Well, afternoon naps, I think nothing more than 1 hour I would recommend. But I don't think there is exact uh, research. But of course, if you are not keeping yourself up at night due to your job, if you're not doing a night duty, if you're not a pilot, you're not a cabin crew member, or operating a machinery, or looking after some other station or whatever, if you are just a diurnal active person, then of course you should be sleeping at night at a stretch. Any other questions? Okay, shall we stop then?
Yes, sir.